Our final talk of this session will be Dr. Vivek Mathew, who will demystify a tricky clinical challenge, how to taper and stop steroids in secondary adrenal insufficiency and glucocorticoid withdrawal syndrome. Let's welcome Dr. Vivek Mathew.
Good morning. First of all, thank the organizing committee for inviting us to this conference. And today we have a complex topic, how to taper down the steroids in a chronically administered state. Like we used to give steroids in respiratory conditions, in arthritis conditions, and when to stop, how to stop, and what should be the minimum level of steroids to be kept as a maintenance dose. All these things will be dealt by Dr. Vivek Mathew. Over to Vivek.
Thank you, Dr. Bisto, for this kind introduction, and I would like to thank Dr. Ganesh and the Endodiabcon team for this introduction. So I will straight away dip into my topic. So the gentlemen you see in the picture there are Dr. Kendall and Philip Hench, and these gentlemen actually extracted the cortisone and cortisol from the adrenal gland, and what you see on the right is the first cortisone acetate from the Mayo Clinic that underwent trial. So this was considered to be a wonder drug, and both these gentlemen won Nobel Prize for that. And cortisone was at that time considered to be a panacea for all the diseases that was there. The side effects emerged a bit later. So the exogenous steroids are a big problem in our country. 1% of all our population uses steroids for anti-inflammatory effects. I could not find a lot of data from India, but then there's one study from the eastern part of India which says that 88.4% of steroid prescriptions were inappropriate, and a significant number was prescribed by alternate practitioners. There was another study from northern part of India which says that 3.5% of patients with euvolemic hyponatremia had adrenal insufficiency due to exogenous steroids. So there is a significant problem that is there. So I will just delve a little bit into the physiology. So you can see from the hypothalamus, a CRH is secreted, which comes down the pituitary, stimulates the ACTH. ACTH secretes the cortisol from the adrenals, and around 5 to 8 milligrams per meter square per day. That is only the total amount of cortisol that is being released every day. Now, in presence of exogenous steroids, as you can see on the other side, just like cortisol, there is a feedback inhibition on the ACTH as well as the CRH. So the ACTH is down, the CRH is down, and the endogenous secretion of cortisol is also down. The trophic effect on the adrenal is off, and the adrenals undergo atrophy. At the same time, you will also find that the diurnal rhythm of cortisol, which is highest in the morning and later lowest towards the night, is disturbed. So this is generally what happens when these patients undergo adrenal atrophy. What you can see on the left is a normal adrenal at the presence of a stimulus like ACTH. It can actually give a normal cortisol response. In presence of an Addison's disease, whatever will be the stimulus, you are not going to get any response. Now, in presence of, let us say, an exogenous steroids and adrenal has undergone partial atrophy, there is some amount of response, but the response is not adequate for the stress that is produced. So, this is an inadequate response in presence of an HP axis suppression. The problem is that the symptoms of a glucocorticoid deficiency or an HP axis suppression is quite vague. So, you may feel decreased appetite, fatigue, muscle aches, low energy. But remember, many of the times, the condition for which you prescribe the steroid, let's say it's rheumatoid arthritis, may have a similar kind of a symptom. Now, let us say somebody develops pneumonia or intercurrent illness. They also will have fatigue, muscle aches, and low energy. So, identifying and pinpointing this glucocorticoid deficiency from this particular situation is going to be quite challenging. So now I'll bring you to a little bit of background terms. One is a physiological dose equivalent, which is basically the total amount of cortisol that is secreted per day, which is equivalent to 15 to 25 milligram of hydrocortisone, 4 to 6 milligram of prednisolone, or 3 to 5 milligram of methylprednisolone. Short-term glucocorticoid therapy, this is considered as any therapy less than 3 to 4 weeks. So there is a very less chance of adrenal insufficiency in this group. Long-term glucocorticoid therapy, that is any therapy more than 3 to 4 weeks of duration at a supraphysiological dose. Now, some people may think that low dose is less than 7.5 mg, medium dose is 7.5 to 30 mg, high dose is more than 30 mg, and there are pulse steroids also. But remember, no form of steroids is free from HPA axis suppression. This is a busy slide, but I would just want you to look into the highlighted areas. If you look at the glucocorticoid potency, an intermediate acting glucocorticoid like prednisolone, it has 4 times higher glucocorticoid potency than hydrocortisone. Now, a dexamethasone has 30 times higher glucocorticoid potency than hydrocortisone. Similarly, the biological half-life is also similarly prolonged. So, these high-dose glucocorticoids technically has a higher impact on HPA axis suppression. So, when you withdraw these high-dose glucocorticoids, you generally have higher risk for glucocorticoid insufficiency during taper as well as withdrawal. Route also matters. For example, if you're actually giving it systemic, they have a higher chance of glucocorticoid suppression than what you give as topical. Naturally, high dose will have a higher chance of glucocorticoid suppression. Duration of use, I told you less than 3 to 4 weeks, the chances of HPA axis suppression is very less. Anything more than 3 months, it is very high. People are obese and people are old age, they are at a higher risk for glucocorticoid HPA axis suppression. So how bad is the route? Let us examine a little bit of detail. If you look at the pooled percentages, you'll find that the biggest culprit is intra-articular injections, something which you don't expect. In fact, the highest risk is for intra-articular injections. Somebody who's got intra-articular injections at least 2 times in the last 3 months, generally they have a high chance of HPA axis suppression. Oral just goes close behind to it. Regarding the dose and duration, as you can see, as the duration increases, the relative risk increases at least 20 times. As the dose increases, the relative risk increases at least 10 times. So now let us see what exactly happens when somebody is on a high dose steroid and you stop it. Now when somebody is on a high dose steroid, you will look at the green line as well as the brown line. The green line represents the cortisol and the brown line represents the ACTH. When somebody is on a high dose steroid, both these are below the reference range. Now at this point, you discontinue the high dose steroids. Then slowly we will find that the ACTH starts increasing. In fact, the ACTH may even shoot above normal in an attempt to stimulate cortisol production. But as you can see the brown line, the cortisol production always lags behind. So it will take a long time before the adrenal gets enough nutrition from the ACTH and the cortisol starts responding. So you have finally the cortisol also starts responding and the diurnal rhythm comes back. So you have a big risk during this period when there is a stress, the HPA axis response is inadequate. So I'll bring you to this particular case. This is one girl I saw in my OPD, 19-year-old girl with weight gain, oligomenorrhea. She had extensive Cushingoid striae and plethora. She was having some tinea crura for which she was using antifungal cream with clobetasol. She was actually using at least 1 tube of clobetasol every week. And you can see the cortisol. The cortisol is actually low. The ACTH is also low. So here, there's another gentleman. He's a 16-year-old man with tiredness, hypothyroidism. He had no Cushingoid features like the other girl, but he had hypernatremia. He was also using a steroid cream around 4 months back. He used it for 3 to 4 years and then stopped. He also has a very low cortisol and ACTH is also low. But because he had no Cushingoid features, we looked at the other pituitary hormones, which is completely normal. So our diagnosis in both these cases was HPA axis suppression. For the girl, we started her on replacement dosage, tapered it down to physiological dose of hydrocortisone. 9 months later, cortisol and ACTH improved and became normalized. Surprisingly for the man, again we did the same thing, but 2.5 years later, still the cortisol is low and the ACTH is also low. So that is an issue which prompted us to look into his pituitary again. And if you can see the pituitary, I don't know whether it is visible there, he has an empty cella. Whether it was some sort of a lymphocytic hyperphagocytis or an insult which produced this isolated cortisol deficiency, we do not know. But in general, an adrenal insufficiency generally with glucocorticoids lasts from 2 to 4 years. So any deficiency after 1 year, I think you should always investigate for pituitary causes. So you should also think of occult steroids, like this other patient of mine who was using a traditional medicine, and when I pointed it out to him that this medicine has some steroids, and I put him on replacement doses, he simply changed his practitioner, and another practitioner gave him another packet of traditional medicine. So he continued using that. So this kind of things can happen. So always look for occult steroids. So when you replace these patients, initiate with hydrocortisone around 15 to 20 milligram, taper down by around 2.5 mg every 2 weeks till 10 mg is reached. If you're using prednisolone, you may taper down to 2.5 mg. But most important, you may face some problems while it is being tapered. For example, while the glucocorticoids are being tapered, one of the most important problems that you may face is that the disease that which you have used it for may actually come back. So flare-up of the primary disease can occur. So let us look at the second case. This is a 70-year-old lady with fracture femur, severe osteoporosis and hypothyroidism. She was sent to me for the management of osteoporosis. She is on 15 milligram of prednisolone. 35 years back, she was admitted in one of the medical colleges following an episode of failure to lactate and amenorrhea. And she was started on 5 milligram of Viceron. And she was told to have it lifelong. If you look into her FSH and LH, it is very low. The diagnosis is probably Sheehan's. An MRI was done. It also showed an empty cellular. But during one of the admissions around 5 years back, because of the stress, the prednisolone was increased to 15 mg. But she never stopped it after that. The problem is anytime you want to reduce it to around 12.5 mg or 10 mg, she develops severe symptoms and she says, I cannot reduce it, right? And she appears quite Cushingoid. So this is actually not adrenal insufficiency. This is a glucocorticoid withdrawal, okay? So there is this is a situation where you have to differentiate between these two. The symptoms could both be the same. In patients who are facing glucocorticoid withdrawal, they can have Cushingoid features. And usually this happens when they're on supraphysiological doses of glucocorticoids. And usually when the prednisolone is decreased below 15 mg, they may have normal electrolytes and even hyperglycemia, unless the hyponatremia in adrenal insufficiency. Here you don't have to test. They may not develop adrenal insufficiency also if glucocorticoids are administered. So it's important to know how to taper. So when you look at the tapering of hormones like prednisolone, you think of concepts like initial rapid tapering. That is when somebody is using around 40 milligram and more, you could decrease by around 5 to 10 milligrams every week. Then once you reach around 15 to 20 milligram, think about gradual tapering where you decrease by around 2.5 mg. And once it reaches around 10 to 10 mg, think of this endocrine tapering. Once it reaches around 5 mg, change to a physiological glucocorticoid like hydrocortisone and decrease by 2.5 mg at least. So there are certain groups, not only oral steroids, there are certain groups which we'll be looking at. One, those patients who are on current or recent use of oral or glucocorticoids with symptoms of adrenal insufficiency. Multiple glucocorticoid formulations. They may be using inhalational, topical, etc. High-dose inhaled glucocorticoids. Inhaled topical glucocorticoids for more than 1 year. Intra-articular injections in the last 2 months. Strong CYP3A4 inhibitors. These patients are at risk. So how do you mitigate this risk? Always use the lowest dose for the shortest time. You avoid formulations with high risk. Avoid CYP3A4 inhibitors. Space out intra-articular injections by at least 3 months. So now you have a patient who is on supraphysiological dose of glucocorticoids. He wants to stop. So you tapered, the glucocorticoid tapering was done. Once you reach the physiological dose, you think of an endocrine tapering. So if you reach something like around 10 milligram with endocrine tapering, and if you feel that cortisol cannot be done, okay, and the patient is coming from remote area, maybe you cannot do the cortisol testing. Just stop the glucocorticoids after continuing physiological dose, but the patient should be aware that he should be closely monitoring for features of adrenal insufficiency or glucocorticoid withdrawal. If the testing is feasible, the biological confirmation is feasible, test an early morning cortisol. That is the best test available. Now this early morning cortisol can be in 3 different ranges. It could be less than 5 microgram per deciliter. If it is less than 5 microgram per deciliter, this patient has a high likelihood of adrenal insufficiency. So here you should continue the glucocorticoid supplement. It could be between 5 to 10 microgram per deciliter. Here it is slightly lower, but here you could continue the glucocorticoids in the physiological dose for a few weeks and then stop. Or you can go for a dynamic testing with ACTH or synactin, and you can check your, if a stimulated cortisol is more than 18, it is excluded. If it is more than 10, you could easily stop the glucose replacement. But remember, this kind of a value is not applicable in stress, pregnancy, maybe let's say an acute illness where the CBG is low, like nephrotic syndrome, CLD, etc. So some of these patients may actually develop adrenal crisis or stress. So how do you manage them? It is simply by giving hydrocortisone 100 milligram IV stat and then 200 milligram infusion over 24 hours. If you do not want to give the infusion, you could give 50 milligram IV Q6H. Some people may present with prolonged vomiting and diarrhea. If that is the case, always use parenteral glucocorticoids because oral absorption is poor. Minor stress, like let's say fever, an infection that does not require hospital admission, you use double the physiological dose and divide it into 3, maybe 20 milligram in the morning, 10 milligram in the afternoon, and 10 milligram in the evening. And moderate on major stress, like hospitalization is required. Here, you use IV glucocorticoids again. So this is a 46-year-old lady who had osteoarthritis of the knee, and TKR was done recently, and she She was on methylprednisolone 4 mg for a long period of duration. Post-op, she developed left lower lobe pneumonia and hypotension. Now, serum cortisol is 10.5 milligram and ACTH is 9. Now, by looking at the values, you may think that this is not HP axis suppression. But remember, this is a case of stress. So here, probably this is a case of HP axis suppression only. So you should think about what to do with these patients during perioperative period. So if these patients are going for a minor surgery, requires only local anesthesia, you can do a stress dose of glucocorticoids, that is 40 mg of hydrocortisone, 20 mg 1 hour before, 10 mg 6 hours after, and 10 mg 6 hours, again 6 hours later. Or if somebody is using prednisolone, you can just double the dose of prednisolone. If it is a major surgery and the general anesthesia is going on and the patient is going to be nil by mouth for a long period of time, give 100 mg hydrocortisone at the time of induction, followed by 200 mg infusion over 24 hours. Once the patient can eat, use a stress dose of glucocorticoids for the next 2 to 3 days. It's also important to prevent an adrenal crisis. So there has to be some amount of awareness for the patient as well as the doctor. You can use steroid cards, which declares that I'm a person who was on steroids for a long period of time. Many of the hospitals and many of the concerns do provide them. And remember, instructions for stress dosing should be given in the steroid card. That also may prevent adrenal insufficiency. Okay, so this is basically one of those movies in the 70s, much after the Nobel Prize discoveries of Edward Kental and Philip Hench. The movie is called Bigger Than Life. In this movie, the protagonist actually develops an immunological condition and for which steroids were used. The movie goes that he was so addicted to the steroids, he starts taking steroids in large amounts and he develops a condition which produces it because of a complication of steroids. Both starts with P. Any idea what they are? The immunological condition and the complication starts with P. The rheumatologic condition, rheumatologic conditions. So he had polyarteritis nodosa, and because of the excessive dose of steroids, he developed psychosis. That is what happened. What's important is, I don't know whether you can see the left side part. So it is mentioned as I prescribed it and he misused it. It's important to know that this movie had Dr. Philip Hench, who is one of the Nobel Prize owners, as the consultant. So I don't know whether this has come from him, but this is something that is there in the poster. So some of the take-home snippets for you. Glucocorticoid-induced adrenal insufficiency is common due to injudicious steroid use. Early recognition and differentiation from other causes is the key. Stress dosing and endocrine tapering of the glucocorticoids need expert attention. So thank you. Thank you for your kind attention.
Thank you, Dr. Mathew, for simplifying such a complex subject. Your clear tapering strategies will guide many real-life scenarios. Dais is now open for discussion.
Vivek, how will you taper down the nasal steroids or topical corticosteroids?
So one of those things is that you should be aware of that inhaled steroids. There is very difficult to taper down the inhaled steroids. But what you really need to know is that any dose of inhaled steroids, if you're using it for more than 1 year, these people have a high chance of HP axis suppression. So what they actually say is any fluticasone doses more than 500 micrograms per day. If you're using mometasone, more than 400 micrograms per day. Budesonide, more than 800 micrograms per day. So here what you have to do is you have to find the lowest possible steroid dose which may be actually responsive to the patients. Then you could recognize the HP axis suppression, and then if the patient has developed adrenal insufficiency, you could taper it over a short period of time. It is very difficult to taper. They may not develop, but then so many of the times the issues are that these patients may develop flares during the time of tapering. That may require use again. So use steroids only if really necessary. That is the only thing which you can be done. And you use a lower strength steroids if possible. And especially avoid steroids like fluticasone propionate, because these fluticasone propionate has a very long duration of action and the biological half-life is also high. So avoiding these kind of steroids would also be of use. So previously the dexamethasone is very difficult, but then what actually says, the current guideline says 24 hours is enough for prednisolone. But then if you look at the biological half-life of prednisolone, it will be around 24 to 36 hours. The safest with prednisolone will be around after 2 days. So dexamethasone will be a little bit more, some 72 hours. But it is important that you shouldn't be, if your intention is basically to prevent HCPS suppression, you should not be using dexamethasone. If you are tapering the steroids, you should change from dexamethasone to prednisolone or hydrocortisone and then check the cortisol.
Many patients are on maintenance steroids for metabolic diseases, say 5 mg less than 5 mg alternate days. So such patients, if they go for surgery, what precautions you take?
Exactly what I said.
You check whether they have some.
No, anybody who's been there for such a long duration, definitely they have HPAC suppression. So you can straight away give the stress dosing for these patients. No need to check.
If there are no more questions, we can wind up the session.